All right, so a pleasant good afternoon, everyone. And today in immunology, we'll be looking at some of the primary immunodeficiency disorders. One of the primary goals of the immune system is to keep us well. Unfortunately, sometimes there are occurrences when the immune system begins to attack itself, a situation which is indeed not very sustainable for extended periods of time. Because if it is, it's like a house fighting itself. So when your immune system begins to attack itself, indeed, that is when a situation that is very dire. And for the duration of this presentation, we'll be looking at certain situations when this occurs, certain presentations in which it occurs as well, and some of the doctor diagnoses associated with them. Let's go. Now, as mentioned, the immune system is the body's primary defense system. It keeps us well. And we often are only reminded of it during situations when we are sick. Now, an immunodeficiency disorder, it means a weak or deficient immune system in some regard. And people with these are sometimes said to be immunosuppressed or immunocompromised. So what causes it? Well, there are a number of reasons, but they can be categorized according to 6 areas. One, a genetic disorder, an infection, certain cancers, treatments involved with the cancers, diabetes, and certain drugs. Let's see if we can break them down. Now, the genetic disorder, this is something that you're born with, though it is very rare. Now, infections, it could occur, such as what happened during the 80s and 90s as related to the AIDS pandemic, not pandemic, but the scourge of the AIDS disease. That is an instance in which viral infection could indeed cause the disease itself. Certain cancers, particularly those that affect your bone marrow, that could be linked with your immune deficiency. Why the bone marrow? Have to remember B cells, which form a very important role in the immuno response to any viral invader. They reside within the bone marrow, the B cells. So therefore, when you particularly certain cancers which affect your bone marrow, by extension, they would affect the B cells and hence affect your immune capabilities. Certain treatments, right? Such as radiation therapy and some chemotherapy as well, they do affect your bone marrow and by extension, the whole immune system. Diabetes as well could lead to compromise of the immune system, and certain drugs. Now, many drugs which doctors use to block inflammation, they can as well lead to the weakening of your immune system. Some of these drugs, which are necessary, are called immunosuppressants. And one example is corticosteroid drugs like prednisone. This is one of the stalwarts of the treatment regimen often prescribed for immunocompromised patients. Sometimes doctors will give you immunosuppressants because your immune system is attacking your own body. And in that case, that is referred to as autoimmune diseases. So what is the frequency of these immunodeficiency diseases, or IDs? It's relatively rare. The primary immunodeficiency diseases, they were originally thought to be quite rare. And some of these are relatively common. For example, selective IgA deficiency disease occurs in as many as 1 in 500 to 1 in 1,000 patients. And this is looking at the US population. Other primary immunodeficiency diseases, they are much less common and occur with a frequency of between 1 in 10,000 and 1 in 100,000. Now, because there are so many primary immunodeficiency diseases, collectively, when they are taken together as a group, they do become a significant health problem. So let's talk about the presentation. We mentioned the frequency. So how do they present? Some of the symptoms include, well, getting frequent infections, such as, so the presentation include infectious diseases. And some of these infections include sinus infections, bronchitis, pneumonia, or air infections. Thrush, which is a fungal infection of the mouth. This is another one that is common with infectious disease associated with it, and lots of sores associated with the mouth. Loss of appetite and weight. This, of course, showing that you do have malfunctioning of the GI tract in its entirety. For a baby or for a child in particular, long-lasting diarrhea and not growing as much as expected. So when you're looking at certain milestones in terms of the growth of the child, when the child is not achieving these milestones, this is definitely a cause for concern. This increased susceptibility to infections is really a hallmark of primary immunodeficiency diseases, and in most cases is manifested by reoccurrence. So again, a reoccurrent infection. So it goes away and it returns, goes away and returns. These infections do not occur only in a single anatomic site, but usually involve multiple organs or multiple sites within the infected person. So these infectious diseases with persons who are immunocompromised, what do we see? Increased, recurrent, and let's look at some of these examples. So the increased susceptibility is the hallmark and is manifested, as we said, by these recurrent infections. Typically, they are seen across multiple sites, and some examples include otitis media in association with recurrent sinusitis and or pneumonia. This is for otitis media in particular. Recurrent sinopulmonary infections such as otitis, sinusitis, bronchitis, and pneumonia. These are the most common presenting manifestations of the primary immunodeficiency diseases. But once again, the recurrent systemic infections such as bacteremia and meningitis, infection of the meninges which surround the spinal cord. These are also seen, not only spinal cord, but also the meninges associated with the central nervous system, both brain and spinal cord. Now, the types of agents which are associated with the infectious disease and the location of the infection, this gives valuable insight into what exactly the nature of this immunological effect is. So that is very important. For example, individuals who have B-cell deficiencies characteristically have an increased susceptibility to infections which are associated with encapsulated pyogenic bacteria, such as pneumococcus and influenza bacteria, and also to enteroviruses. On the other hand, patients who are deficient in T cells may have infections with a variety of microorganisms, but they do appear especially susceptible to fungi, viruses, and pneumocystis. Patients with complement deficiencies, we mentioned in earlier lectures that the complement system, this really augments the proper functioning of the immune system, often present with bloodborne infections such as bacteremia and meningitis. And these patients also present with phagocytic disorders, and they characteristically have infections associated with the skin and reticuloendothelial systems. So let's talk a little bit about these other things which could affect it. So we mentioned some areas where you could have infections presenting themselves. Let's talk about some rheumatic diseases. So the autoimmune and rheumatic diseases, they're more commonly seen in some of the primary immunodeficiency diseases. There's more patients in some more than others. Some of these diseases include rheumatoid arthritis, systemic lupus, and or dermatomyositis. All right, so these are three characteristics or characteristic diseases which are often seen with primary autoimmune disease. They're also relatively common in selective IgA deficiency, common variable immunodeficiency, and deficiencies of the complement system. But they are relatively uncommon in X-linked gamma globulinemia diseases. So we speak about the infectious diseases. Let's move on now to the GI tract, those that are associated with the gastrointestinal tract. Now, chronic diarrhea, which malabsorption and even malnutrition are important manifestations of primary immunodeficiency diseases, particularly in infants and young children, which is why it's always very important, particularly when you see young infants and children, they're sick with GI tract infections, to ensure by screening that it is not an inherited or otherwise immune compromised related disease. Now, chronic giardiasis, rotavirus, and cryptosporidium, among other infections, they have each been significant problems in patients with primary immunodeficiency diseases. Now, you do have some that have non-infectious etiologies in terms of the progressive disease, and this includes inflammatory bowel disease, gluten-sensitive enteropathy, particularly in these health-conscious days, atrophic gastritis with anemia, and nodular lymphoid hyperplasia in terms of swelling. We looked at the GI tract. Let's look at some of the blood or hematologic diseases. Now, anemia, thrombocytopenia or leukopenia are seen frequently in patients with primary immunodeficiency diseases. For example, the Wiskott-Aldrich syndrome is characterized by variable defects in both B and T lymphocyte function. So these patients, they also have intrinsic abnormalities of their platelets, which result in small irregular platelets being seen when a blood test is done. And speaking about blood tests, this is one of the ways in terms of the doctor's diagnosis, how it is actually seen or how it is revealed that the person does indeed have this ailment. Let's have a look at it a little bit in a little more detail. Now, if doctors do suspect an immunodeficiency disorder, they will detect it if, upon asking questions in terms of the diagnosis, you find that you have been sick a lot, your sicknesses are often severe, or you don't respond normally to treatment. So what they usually do then is order a blood test, and this test may show a very low white blood cell count or low levels of substances made by your immune system. Because especially since we've just, well, not just, but within the 80s, that's 30 odd years ago, 30, 40 years ago, but that is always hoovering the whole issue of HIV. So one of the things that is often screened for is HIV, and you will be often given a test to see if you have risk factors for infection, HIV. Now, depending on your symptoms, doctor may also do some skin tests that tell how your immune system is working. You might biopsy some of your swollen lymph nodes if they are swollen, or sometimes they will have a look at your bone marrow. So the treatments, some of the treatments, right? Of course, antibiotics, stem cell transplantation. Let's speak about them in a little more detail. Now, if a medicine you're taking causes immunodeficiency, the doctor might decrease the dose or have you stop taking it. And then he or she will consider how much you need the medicine and how bad the immunodeficiency is, while of course deciding whether to stop, decrease, or choose another medication. If the immunodeficiency has caused an infection, of course, he or she, the doctor, might resort to giving antibiotics, immune globulin, which is simply antibodies from the blood of people who do have a healthy immune system. And if your immune deficiency disorder is caused by a bone marrow problem, well, the doctor might want to look at stem cell transplantation. Of course, these stem cells, they develop into blood cells, including the white blood cells, and they will assist or help your body then fight off the infection. So that's the doctor's treatment. Of course, the doctor has to send the screening to the lab. And what happens in the lab? The evaluation of the B lymphocyte function, the screening is a measurement of serum immunoglobulins. So you have a quantitative measurement of the serum IgG, IgA, and IgMs, and this will identify patients who have a deficiency of specific classes of immunoglobulins, such as selective IgA deficiency. Now, there are 4 subclasses of IgGs, and in some instances, the total serum IgG may be normal or near normal, but the patient may still have an IgG subclass deficiency. So proper assessment of antibody function is a necessary part of the evaluation of humoral immunity. Titers, antibody titers after immunization with protein antigens, for example, might be familiar with tetanus or diphtheria toxoids and polysaccharides. These are the most convenient type. Now, if the immunoglobulin levels are decreased, the evaluation should proceed with more advanced tests of B lymphocyte numbers and function. There's also evaluation of T lymphocyte function, right? Bone, thymus, matured cells, important parts of the immune system, and testing for defects in these T lymphocyte function is relatively difficult because of the fact of the lack of inexpensive and reliable screening tests. So delayed type hypersensitivity or DTH skin tests using a panel of ubiquitous antigens can be used as a screening test in older children and adults. The presence of a positive DTH test, this generally indicates an intact T cell function and cell-mediated interventions. So this T cell functions in terms of more specialized tests, right? These include an assessment of lymphocyte proliferation, notwithstanding the skin test. You could do an assessment of lymphocyte proliferation in response to non-specific mitogens. And you could do specific antigens and or mononuclear cells from an unrelated histoincompatible individual. And this could also be used in testing specialized, the testing functions, of the T cells. It is also possible in some laboratories to measure the production of a number of different cytokines that are involved in T and B lymphocyte regulation. The phagocytotic function analysis, reductions in the phagocytotic cell number, the macrophages, in the peripheral blood, and therefore collectively in the immune system, can be detected by using a white blood cell count and differential cell count. So finally, you'd want to look at the complement system. And the analysis for the complement system involved the CH50 assay. Now, the CH50 is a screening assay for the activation of the classical complement pathway. And it is sensitive to the reduction, absence, and or inactivity of any component of the pathway in terms of the complement system. Now, the CH50, it tests the functional capability of the serum complement components of the classical pathway. And it does that comparison in the ability of these cells to lyse sheep red blood cells, pre-coated with rabbit anti-sheep red blood cell antibody. Now, when the antibody-coated SRBC or the sheep red blood cells are incubated with test serum, the classical pathway of complement is activated, and usually hemolysis results. If a complement system is absent, the C50 level will be 0. If one or more components are decreased, the C50 will be decreased. So therefore, by doing a comparative analysis with a normal, you can then gauge the strength of the complement system. So finally, in terms of some of the examples of primary immune diseases, these are given here: X-linked disease, common variable, selective IgA deficiencies, and you also have chronic Wiskott-Aldrich syndrome, and DeGeorge syndrome as well. All of these are examples of primary immune diseases. So in terms of with compromised immune system, very important to note that it is probably one of the more debilitating diseases which could affect an individual because the essence of the immune system, that ability to recognize self from non-self is lost. And therefore the body then begins to attack itself in the case of autoimmune diseases. All right, and that will end the presentation for today.